Geriatric emergency medicine wing of Society for Emergency Medicine India started in 2015, and we have done conferences on geriatric emergency medicine, and we have done workshops on geriatric emergency medicine. I also represent the Geriatric Emergency Medicine wing of International Federation for Emergency Medicine, and we are very passionate about this field of emergency medicine. And there's a lot to study, because more than 50% of our emergency care medicine department census is of the geriatric age care. So knowing about this age group, what the diseases you see commonly in this age group in our emergency departments, and to make tailor-made protocols specific to geriatric care is a need of the hour. Why? Because in 2050, India will be having the highest geriatric population in the whole world. Geriatric emergency or geriatric medicine would have started in America or any other the Western European countries or the Western part of the world. But in 2050, India will be, right now India is the diabetic capital of the world, but in 2050 India will be the geriatric capital of the world. So being the geriatric capital, you will have more increase in the number of geriatric patients presenting to your OP or ER, and making tailor-made protocols, improving home health care, and improving geriatric centers like Atulya and all other more home health care and home geriatric care, and improving geriatric care as a specialty will definitely decrease the burden of geriatric patients on our emergency. Hope you will agree with me. So half of the patients who present to our ER in geriatric age group, they necessarily don't want an ER. They suffer from loneliness, they suffer from age-old ailments, starting from ordinary lower limb pain, an ordinary myalgia. Do you agree with me? In the ER, you feel there is a lot of that is asymptomatic or unnecessary geriatric patient visits, whom we convert as admissions. In a study in India by the AIMS, more than 20 to 30% of geriatric patients getting admitted in any hospital, the admission is unnecessary. If the patient had a regular follow-up with the general practitioner or a geriatric specific physician, more amounts of ailments can be treated at home rather than making the patient come to the hospital, like checking the sugars regularly to prevent hypo or hyperglycemia, unnecessary falls at home, and psychosocial illness because of deserting of their own parents by the middle-aged men or women, and lot of patients who already have neurological illness which is not so serious that they require a ventilator or emergency department, like delirium, psychosis. So today's our workshop is going to be on the same. We are not here to cover geriatric medicine per se. We are here to cover geriatric emergency medicine, which is just an extension of geriatric medicine happening at the emergency room. We will not be able to cover 360 degrees. We have specific talks by leading geriatricians of our hospital. We have a special wing in Kamakshi called Dr. K. Elder Care, which caters only to the geriatric patients by visiting them at home, finding their illness early and treating them early, and avoiding unnecessary hospitalizations. Or if the patient is very sick, they are the patient, the Elder Care takes enough care to bring them to the emergency and ICU within the golden hour, and post-op, after surgeries or after discharge, the follow-up is done by the Elder Care unit. So without Elder Care unit, definitely I would say that the geriatric care, we will be loaded with geriatric patients. So every hospital should have a geriatric wing and a geriatric emergency medicine focus to prevent unnecessary hospital admissions, to improve the geriatric care patients. See, by concentrating on geriatric care, main what advantages you as an emergency physician will acquire. You will acquire more skills. You can, as an emergency physician, you concentrate on A, B, C, airway breathing and circulation, or circulation, airway and breathing in ACLS and BLS. But in geriatric age group, there should be an even more emphasis on the family history, the socio-economic history, and the atmospheric history. That's what they say in geriatrics. In what environment that the person, the geriatric age group lives or dwells in, who are his relatives who are immediately taking care of him, how is the caretaker. Geriatric is a whole lot of this 360 degrees. So it is very, very impossible to cover the entire geriatrics in one day, but we will do justice in this one day for all those who are attending. So we have conducted various workshops since 2015, but this workshop we have included, usually we cover delirium, coma, we cover medical legal aspects in elderly patients, air ambulance transfers, polypharmacy, and the frailty score, and the psychosocial illnesses which are present in the geriatric age. These are the regular talks which happen. The diabetes in elderly, the trauma, fractures in elderly, the cardiac issues in elderly, endocrine issues in elderly. So elderly 360 degrees we cover, and it will be exclusively talks. This time we have taken an initiative to restrict the talks before lunch and post. Lunch may be having very good workstations, and we wanted to keep the crowd limited. We initially got about more than 100 requests, but we really wanted to only cater to 25 registrations so that we can give individualized attention to each one of you. And this should not be like a conference, so you come, you attend, you get a certificate and leave. No. We want each one of you is attending, ensure that you get adequate geriatric medicine or geriatric emergency medicine knowledge today. And tomorrow when you go back to your practice and emergency, definitely we want you to create or make a difference in your departments. So with this note, I pledge that today you will be having a big meal for geriatric emergency medicine. So thank you once again for making your time today. Thanks for all your heads and consultants who have allowed you to take a day off for the geriatric emergency medicine, and we will definitely do justice.